General, Department of Health, South Africa, and representative of the Honorable Minister of Health, Ambassador Beck, distinguished guests, colleague members of Health Systems Global, ladies and gentlemen, it is with great pleasure and a sense of privilege at being part of the unfolding of yet another landmark in the history of health policy and systems research that I stand here at this opening ceremony of the 3rd Global Symposium on Health Systems Research. It seems like only yesterday that we were in Beijing and Health Systems Global was formally inaugurated, and we promised each other that we would meet again in 2 years' time. At that time, we didn't know where we'll meet. And I'm excited that we are meeting in Africa, in South Africa, in the land of Nelson Mandela. Okay. There's a Nigerian proverb that says that a goat that belongs to the whole village belongs to nobody. Health systems are many times, unfortunately, in that situation of this goat that belongs to the whole village and therefore belongs to nobody. Despite the fact that implementation of interventions, attainment of program targets, goals, and outputs depends on strong and well-functioning health systems, paradoxically, national governments, development partners, communities, individuals, all hesitate to invest in something that is not easy to hold, measure, and claim as my output and my contribution. You cannot draw a nice graph of what you have achieved by contributing to health systems. You can draw a nice graph of what is happening to deaths in malaria or immunization and so on. And yet, those attainments depend on the health system. The problem is particularly acute in less resourced nations of the world because as resources become short, the first person to get neglected is this goat, which belongs to the whole village and belongs to nobody. Okay. It takes a crisis, like a tragedy, like Ebola, to wake people up to the dire consequences of this neglect. And it is said that it's an ill wind that blows nobody any good. We hope that this dreadful tragedy, which we would prefer have not occurred, will further help us to realize the importance of this area. The establishment of Health Systems Global and the co-hosting by Health Systems Global of the 3rd Global Symposium is a further welcome step in drawing attention to this area of work. Before I invite the speakers, I would like to just take a minute. 2014 has been a very difficult year for the world in terms of disasters and crisis and tragic loss of life. At one point, I thought the world is not going to be able to hold it anymore. Everybody is going to fold up and say, enough crisis. However, we are very resilient and we still go on. And things like Palestine, Syria, Ukraine, the downing of MH17, and now Ebola, particularly because we are in Africa and talking health systems, I would like us to take just a minute to reflect and to remember the many health workers and other people who have lost their lives because of Ebola, and also those who continue to struggle with it on a day-to-day basis, ordinary families, people, volunteers. And in remembering, let us determine that we will continue to make sure that this goat that belongs to the whole village and whose milk feeds all the children in the village gets the attention it needs. Welcome. Thank you. Our first speaker was Dr. Margaret Chan. Unfortunately, she was unable to come, but she has sent us a video, and I would now like to invite us to watch this video. Thank you.
Greetings from the World Health Organization in Geneva, where I am heavily involved in coordinating the international response to the outbreak of Ebola virus disease in several West African countries. The work you will be doing during this symposium, the issues and ideas you will debate are absolutely essential. I believe the world and its leaders are finally ready to recognize the vital role played by health systems research. What does the Ebola outbreak that has been making headlines for months tell us about the state of the world at large? What does it tell world leaders and the citizens who elect them about the state and status of public health? One thing is now vividly clear for everyone to see in the headlines and on their TV screens. Decades of neglect of fundamental health infrastructures mean that a shock, like an extreme weather event, a conflict, or a disease run wild, can bring a fragile country to its knees. Better health is a nation-building strategy. Without fundamental public health infrastructures in place, no country is stable. No society is secure. No resilience exists to withstand the shocks that our 21st century world is delivering with ever greater frequency and force. You cannot build health systems up during a crisis. Instead, they collapse. The fact that no fundamental public health infrastructures were in place in Guinea, Liberia, and Sierra Leone is what allowed the virus to spiral out of control. As the world suddenly sees, nearly everything is missing. Inadequate numbers of staff, hospitals overflowing or shut down entirely, not enough personal protective equipment or training in its proper use, little understanding of measures for infection prevention and control, big discrepancies between the quality of care in public and private facilities, few incentives to seek health care early, as the disease has no vaccine or cure. To meet the needs of affected communities, health officials and their partners need context-specific evidence about the most appropriate and effective mechanisms for delivering essential care. You will be touching on these issues in the coming days. As we all know, access alone is not a sufficient marker of adequate health care provision. Health systems must be people-centered. They must respond to the needs of people who receive services and not just the needs of those who deliver. Your research enumerates the many reasons why. Here is one of the few things that I'm glad to see as the number of Ebola cases continues to rise exponentially. When presidents and prime ministers in non-affected countries make statements about Ebola, they rightly attribute the outbreak's unprecedented spread and severity to the, let me quote, failure to put basic public health infrastructures in place, end of quote. Research will help the international community correct this failure. Perhaps messages about the importance of health systems, so forcefully articulated in your previous meetings and so well backed up by your evidence, have begun to sink in. It is high time they did. I wish you a most productive meeting. Thank you.
Okay. It is now my pleasure to introduce Madam Deborah Birx, U.S. Global AIDS Coordinator. Ambassador Birx is Ambassador at Large and Coordinator of the United States government activities to combat HIV/AIDS globally. Ambassador Birx is a world-renowned medical expert and leader in the field of HIV/AIDS, whose 3-decade-long career has focused on HIV/AIDS immunology, vaccine research, and global health. As the U.S. Global AIDS Coordinator, Ambassador Beck oversees the implementation of the U.S. President's Emergency Plan for AIDS Relief, PEPFAR, the largest commitment by any nation to combat a single disease in history, as well as all U.S. government engagement with the Global Fund to fight AIDS, tuberculosis, and malaria. From 2005 to 2014, Ambassador Beck served as the director of CDC's Division of Global HIV/AIDS in the CDC Center for Global Health, where she led the implementation of CDC's PEPFAR programs around the world and managed an annual budget of more than $1.5 billion. We are privileged and we are honored to invite Ambassador Beck to the stage.
Good morning. Thank you for that kind introduction, and it's a real privilege to be here. And thank you for your title that talks about health systems being patient-centered and people-centered. I think this reminds us every day that in the face of stigma and discrimination, our healthcare workers have to provide that opening, that welcoming, and ensure that in all communities feel welcomed into the healthcare community. You all know where we have been with HIV/AIDS, and at this time where we've made enormous progress, there is still much left to be done. Although we talk about the potential for controlling the pandemic, in the majorities of countries in sub-Saharan Africa, the pandemic is in no way controlled. PEPFAR has contributed to life-saving interventions, including 6.7 million people on treatment. That's our number from 2013. Our new numbers will be released in November. 4.7 million men, voluntary medical male circumcisions, 17 million people receiving care, of which 5 million are orphan and vulnerable children. And 21 million people reached with prevention interventions, including key and vulnerable populations. Last year alone, we tested with rapid tests, primarily, almost 60 million individuals for HIV. You can imagine the frontline healthcare workers that need to be available for 60 million tests in 12 months. Totally, we've contributed about $52 billion to the HIV/AIDS fight and to TB, HIV, and malaria through the Global Fund. But importantly, a significant component of that $52 billion, probably between $5 and $6 billion, has been dedicated into horizontal health system development, including healthcare workers, infrastructure, and the necessary work with the ministries of health for policy reform. This shows how much progress we've made in the epidemic, the big blue mountain representing sub-Saharan Africa. And you can see since the peak of the epidemic that incidence and new infections has decreased by almost 50%. All groups show that level of decrease except the continuation of continuing infections in Eastern Europe and Central Asia. But that dramatic progress shown on the prior slide is not equal. All countries have not had the same decrease in new infections as seen in that overall analysis of sub-Saharan Africa. Indeed, there are countries today where the incidence is actually increasing in sub-Saharan Africa. And if you break this down and you become more granular and you look at the progress in comparing countries that are very similar in their healthcare worker and infrastructure capacity, similar in the peak of the epidemic, shown here in the blue dotted line are new infections and the red line, deaths in HIV/AIDS positive patients, you can see a dramatic difference between Mozambique and Malawi. When you look at these and analyze them, the true difference between these two countries has been the accessibility and to both life-saving as well as prevention care services throughout these two countries. And so even though the healthcare workers, number of healthcare workers of both physicians and nurses are very similar at the community level, the ability to deliver services is dramatically different. Analyzing these different countries at the level of the health system gives us more detailed information about how we can have broader delivery of services in different situations. So what will it take to deliver an AIDS-free generation? We like to call this at PEPFAR now the right things in the right places at the right time. And what does that mean? Fortunately, we've been guided by science for exactly what the right things are. We know that the right things are what we now term combination prevention, which is integrating prevention services with care and treatment services and ensuring all of those that are reached. We also know in our analysis that there are populations that have been left behind, that specifically we need to look at why have they been left behind, why is their incidence on changing, and how is the health system, the people-centered health system, not reaching these key vulnerable populations. When we did this right thing reanalysis in a level budget situation in Uganda, when we saw the increasing incidence in Uganda, we immediately deployed a team who worked very closely with the US government team on the ground, as well as the Ministry of Health, faith-based organizations, and NGOs, to really alter the US government investment to where it would have the most impact. You can see in this level budget of the blue bars, there was a dramatic increase in accessibility of treatment, almost a doubling of the treatment. And importantly, Uganda was able to roll out what we call B+. That is offering to pregnant HIV-positive women the ability to have lifelong ART that not only protects them during pregnancy so they are healthy and well, but keeps their baby from getting infected during pregnancy, postpartum, during delivery, and during that critical breastfeeding period, and then through the next pregnancy. You can see in the orange bars the dramatic increase in testing, accessibility of testing to all HIV pregnant women, as well as in the purple bars, the dramatic increase in the ability of getting these mothers onto lifelong ART, all in a budget-neutral situation. And this is what was able to be done with voluntary medical male circumcision. So we can see with focus, commitment of the health systems, the infrastructures that are required, ensuring that you're focusing the right things at the right place. And what do we mean by the right place? We all have seen these diagrams of prevention, prevalence, HIV prevalence. This is an example from Tanzania. You can see there's a dramatic difference in prevalence between different areas of the country. So some areas of the countries have very high prevalence of nearly 14%, and other areas of the country have 2% or less. When you break this down, so that's the prevalence number, when you put it into the population context, it really gives you an idea with the dark red showing the number of people that need to be served with HIV/AIDS. This allows us to reorganize human resources with the ministries of health as well as the commodities necessary to treat the volume of patients that are required. When we did a comprehensive analysis at the most granular level, and if I leave you with anything today, it's the importance to translate our big picture down to the actual site of delivery and understanding what is happening at the site level. Without that understanding, we cannot prioritize commodities, we cannot prioritize our human resources, our health, and we cannot prioritize funding. So when we did this analysis in Tanzania, we looked at our prevention of mother-to-child transmission testing sites. And you can see a significant number of our sites, nearly 32% of the sites, had no HIV positives. What does this say? In our development of our hub and wheel structure, where we went to the most decentralized areas, when we got to the far reaches and the most distant communities, we have found that there are communities that have been spared from significant HIV/AIDS. This is an important piece, and translating these clear site information into revised maps of where HIV is and where HIV isn't is allowing us to not test in areas where there isn't HIV and up-refer into provided initiated testing at the health center. This does a very important thing. This says to the healthcare worker that maybe have quite limited numbers at the health center that their need to test for HIV is not there, and their focus can be on malaria or diarrheal diseases or respiratory diseases and under 5 survival or maternal child health. You can see that there were also a significant number of sites that were low yield, but importantly, 13% of the sites were seeing nearly 70% of the patients. This means that these sites probably did not have enough human resources to really meet that need. Now, if you break this down further, again, this gets to the actual site level. So this is looking at individual sites, and you can see on that bottom where you can't see any graphics at all, this piece right in here. Let me see if I can, these. These are all of the sites with no positives, and then some sites with a few positives. So 90% of the patients are at 37% of the sites. This kind of granularity is really critical when you're trying to organize a comprehensive response to ending the epidemic. Importantly, though, this information, this granular information of number of positives can be now translated into site maps, whereas before we had large block prevalence of overarching HIV positivity. Now you can see that it's really isolated in a corridor that follows a major road. And if you further look at this at the site level, we'll be able to tell us specifically what villages and what communities need enhanced prevention, care, and treatment interventions. And what do we say about the right time? The right time means trying to immediately translate WHO guidelines into practice. So we're talking about making data available, making data digestible, and making data actionable, so that all of those pieces come together to really allow us to move quicker and faster to controlling the pandemic. I just want to mention a little bit on leaving no one behind. This is an important map, and I think it's very telling to all of us. This is what key populations vary by location. And you can see in sub-Saharan Africa, the largest blue circle represents young women. All the other vulnerable risk groups fit within this large blue. This tells us that in sub-Saharan Africa, all of our work in the most vulnerable groups, or a significant part of the work, needs to be addressing young women and their unique risk factors and ensuring their accessibility to the healthcare system. And this gets back to the piece of a people-centered approach. What do young women 15 to 24 years old really need in assessing the health system? Are the health centers welcoming to young women? Do they have specific adolescent programs? Do they have testing programs that are specifically oriented to young women? Do they feel welcome? Do they feel like they are not judged when they come to the health center? And this is the very issue that we're talking about. Prevalence in young women of new infections and their incidence is twice young men in every country in sub-Saharan Africa. But we also have to remember that all of our overlay, including our most vulnerable populations of men who have sex with men, people who inject drugs, sex workers, are particularly and often discriminated in the health care centers as well as in the community. And indeed, there are specific laws on the books as opposed to South Africa. South Africa is very green here, showing that they have protections and rights-based protection. Most of sub-Saharan Africa does not, leading to alienation and people feeling unwelcome to assess healthcare services. Science and research. I think the other piece of this talk that we would like to just emphasize is the utilization of this big data. PEPFAR has a lot of data. We haven't made it often available. If you go to pepfar.gov today, however, you can see all of our results for every country and all of our budgets broken down by budget code, where our investments were and what results have been achieved. That data can be used for further analysis, including utilizing program data for unique science and research opportunities. This will give us the ability to, with our collaborations and with our partnerships with host countries and local universities, to really look at what are the most effective means of scale-up, adherence to medication, what are the problems in implementation, and when all of the countries are up there together, it allows South-South coordination of addressing problems. How to improve equity and efficiency, how to improve a culture of learning, how to better engage stakeholders, and how to achieve better health outcomes, which is, I know, why each and every one of you are sitting in the audience today. So this is a combination of how we're looking at our health systems research as well as our scientific research to support all of our work. We still have a significant amount of work to do in TB HIV. As I mentioned, reaching adolescent girls and young women with a combination of interventions that will be most effective still needs additional work. This week in Washington, or the beginning of next week, there'll be an announcement of a model that came specifically out of South Africa on how to improve our care for orphans and vulnerable children. And what type of healthcare or cadre need to be available to specifically support orphans and vulnerable children. We know that with controlling the epidemic, penultimately we'll need an HIV vaccines and effective microbicides. Again, South Africa has been leading the efforts both in HIV vaccine research as well as microbicide research. We think key to a lot of our work will be long-acting ART, or long-acting treatments, so patients could come to the clinic and get a long-acting injection that may last for 1 month, 2 months, or 3 months, therefore increasing adherence, but also decreasing the amount of constant interaction with the healthcare system. In general, our response to HIV/AIDS has really been characterized, we believe, by strengthening overall epidemiologic and laboratory services. I'm not going to go into the details here, but I hope many of you know about the African Society for Laboratory Medicine, a fully African-led group that is working on leveraging all of sub-Saharan Africa to improve laboratory at all levels. All countries have now developed national laboratory strategy, tiering of testing, tiering of the health cadre needed at each of the sites, what specifically will be done at the health center, district hospital, regional hospital, and referral hospitals, and then normative, usual quality control that's being done at each of the facilities, by the facilities, and then cross-checked by the African Society for Laboratory Medicine. Strengthening of civil society, where still additional work has to be done, and then increasing our access to antenatal care through our Saving Mothers Giving Life and our HIV cancer, cervical cancer prevention. Overall, we think that through PEPFAR and the laboratory strengthening and the health care strengthening that has occurred in the human resources for health, that these have been important in outbreak detection, control of avian flu, Ebola, and cholera, and hemorrhagic fever in a whole series of countries outside of Liberia, Sierra Leone, and Guinea, where there are not substantial PEPFAR resources. We think key to this has been healthcare information, but importantly, the feeling that the community will receive the appropriate health care when they go to the health center. That trust between the healthcare delivery system and the community we can see is absolutely critical for not only sustaining the health system, but in responding to these outbreaks and other key issues. We believe that universal healthcare coverage is part of what is being achieved during epidemiologic control of HIV, and these synergies assist in the data systems. Getting this level of granularity of diseases and the response will be absolutely critical to ministries of health. The partnership with civil society so that there's constant advocacy for improved healthcare systems, investment in healthcare delivery and training through our NEPI program, our nursing program, our MEPI program, our medical program, our FELTP field epidemiology program, through C Global Health. I could go on and on with acronyms, but the reason we have a plethora of health cadre training both pre-service, post-service, in-service, and this is now all being coordinated by Janice Timberlake, who will be here all this week, to really figure out how we can best leverage all of those resources to have an optimal impact, not only for HIV/AIDS, but the overall healthcare delivery system. Finally, I want to leave you with 2 slides. We are very serious about improving our openness, our accountability, our transparency, and our impact. And so really, please go to our website, look under data and results. All of the site-level data, which is being launched right now, which will include at the site level the cost of achieving the results through our expenditure analysis, the actual results achieved, as well as the quality of those results through our quality monitoring system, will allow you to see all of the components in one place and allow you to do that kind of analysis of performance and impact. I want to end with the sustainability index that Janice Timberlake has been working on with a large team back in the US. The slide is not important for the level of detail. The details are extremely important for the team, but I wanted to show you it's a grading system that puts everything into one page. so that people can quickly evaluate the investment, the local investment, the PEPFAR investment, the Global Fund investment, how the epidemic is doing, how we're reaching patients, how we're having an impact, what are the particular risk groups. And this comprehensive analysis will then come out as a schema of where we need to work, which will give us the metrics. We talked about not always having, as in the opening, not always having the metrics that we need so that we can show that we're having improvements in the health system. This is all about developing those metrics in cooperation with our host countries to ensure that we have that impact. But I want to leave you with one final piece, because I know a lot of people have become complacent about HIV/AIDS. But I wanted to let you know that while you are here this week on this continent, 4,600 babies were infected because of a lack of our ability to implement comprehensive prevention of mother-to-child transmission, as has been done in South Africa, where they have virtually eliminated pediatric AIDS, where over 36,000 adults became infected, of which 7,000 of those are young women, where our programs are obviously not reaching them effectively. 3,600 children died this week due to lack of services, either diagnosis or treatment, or a combination of those, and 25,000 adults died this week. So as you're here and as you're discussing how to improve the health systems, remember between every one of these numbers is a family, a mother, a father, a teacher, a healthcare worker, a laboratorian, one who is working on burying the bodies of others. All of them are at risk for HIV/AIDS, and we have to remember at the center of all of this is improving our responses and ensuring a durable legacy for long-term prevention of HIV. Thank you.
Thank you very much, Ambassador Bex. It is now my pleasure to introduce Ms. Malibona Precious Machocho. I hope I pronounced it right. Good. Okay. The Director General of the National Department of Health South Africa and a member of the Executive Committee for the organization of the Third Global Symposium on Health Systems Research. Ms. Machocho is Director General of the South African Department of Health, a position she has held since June 2010. She has a master's degree in law and ethics from the University of Dundee, a degree in pharmacy from the University of the Western Cape, and a postgraduate diploma in health management from the University of Cape Town. She has worked in both the public and private sector at management level and was a director in public health innovation and intellectual property in the Office of the Director General of the World Health Organization. Former leadership positions include her appointment as a head of the Medicines Control Council, serving as a member of the National Research Ethics Council of South Africa, and as director of the Essential Drugs and Traditional Medicines Program for the Department of Health. She has been a member of various advisory panels locally and internationally with a primary focus on improving access to medicines. Madam DG, thank you.
Good morning. I didn't hear you. Good morning. Good morning. Thank you. Ambassador Bex and the program director, who's also been the chair of the organizing committee of this global symposium, and other members of the executive committee. I would like to thank you, but I'd like to welcome you all to this symposium in South Africa and welcome you to the African continent. I'm both happy, but concerned as well. Happy because this conference is taking place here at the foot of this majestic Table Mountain at our mother city, but concerned that at this time, as we are sitting here, the Ebola cases are now over 6,000. But I'm also pleased because this morning at 5:20, 4 of South African scientists arrived who had just set up a mobile laboratory in Sierra Leone. They had sent a replacement team which arrived last week. And all what I could say at 5 a.m., because I was waiting for them to tell me that their plane had landed and that they did not have difficulty with my own port health officers because they are refusing them entry back home after they had done stunning work. So these countries, as you know, that have been plagued by Ebola recently are post-conflict countries. They have, over the years, in the last decade or so, worked hard to put their systems back at work, to build their economies, to build their health systems. But now, being faced with colliding epidemics of HIV, AIDS, and other communicable diseases, and emerging non-communicable diseases, they also have to deal with the critical problem of fragile health systems that have over the years been undermined by conflicts. They're under threat at the moment of complete collapse of their systems, and it brings to our attention in this conference why health systems are important and why all of you should use this as an opportunity to find effective solutions of performing health systems. In the recent New England Journal of Medicine, Greg Midman reminds us in an article about the history of medicine that it's actually not the first time that West Africa has had a disease outbreak. They've had this in the 18th century, and they've seen this in the 20th century. But at the time, what brought West Africa to global attention, to be the subject of global attention in 1928 to 1929, was because there was a yellow fever outbreak that claimed lives of medical researchers from Japan, US, UK, but also educational advisors. It is of interest to note that at the time, there was a team sent from Harvard to find solutions to the outbreak. And we are seeing again in West Africa a similar kind of response. At the time, it was the League of Nations that took a decision. This time, it is the United Nations that responded. So when we build strong health systems, it is obviously necessary that it must be informed by research, there must be evidence. It is for that reason that this symposium, and I'm happy to also call it a GPS of health system decision-making. So let this GPS of health system decision-making that was referred to in 2012 generate evidence that can help us respond adequately, that can help us as policymakers make appropriate decisions, that can ensure that our planning is informed and can result in good health outcomes. While funding constraints have led to the neglect of research in many countries, there are other factors that have contributed to underinvestment in health policy and systems research. And my appeal today is that as we invest in programs, as we invest in health systems, let's also invest in health systems research so that we can better respond and respond adequately and speedily. We need to do the following. We need to find research champions in key areas pertaining to the health system and health service delivery. We need to promote the culture of conducting research and ensuring that we can deal with perceived risks and difficulties. We need to deal with the capacity, particularly in resource-limited settings, of conducting analytical research. It is my hope that hosting this global symposium on health systems research in Cape Town, particularly in this continent, will inspire and reinvigorate health professionals, health service managers, researchers, to overcome this problem, and it will also encourage policymakers to support research efforts and invest in research. Because the theme of this conference is about people-centered health systems, I would like to underscore the importance of recognizing people as the central focus of our work, of putting resources in a manner that can help us respond adequately, but to both users and providers of services. People-centered health systems must ensure that we respond both at population and patient level. And our system in South Africa is shaped by the Constitution, in which Section 27 makes provision for the right to health. So it protects and secures people's health rights, but it is also given impetus through our National Health Act that centers around provision of equitable and quality health services. But what I like most is that we've got a patient rights charter, which puts responsibilities on users of services, the patients, but it also reminds us of our obligations as those who provide services to patients. So I'd like to share with you the following messages: that let's put quality as a way to improve our people-centered approach towards healthcare service delivery. Let's strengthen healthcare leadership and management and recognize the fact that engaging patients and communities is not only necessary, but it's our obligation. Let's set and implement governance structures that are functional, that can also serve as a voice to communities and those who use our services. People-centered health systems encompass rights. It also puts responsibilities, as I said earlier, to carers, to health workers, to advocates, to administrators, planners, and yourselves as researchers. It will also ensure that we are all accountable and that we can find expression in some arrangements, in laws, in policies that we make, and whatever we do can stand public scrutiny, and we can look at ourselves and be satisfied with services that we render, with decisions that we make on a continuous basis. I would like to take this opportunity to thank Professor Mayosi for taking leadership and asking us as government in South Africa to invest in young South Africans and make them researchers. It has forced us to come up with a vision that in 10 years, we must have 1,000. In 10 years, we must have 1,000 PhDs, meaning we must produce 100 per annum. These must be for clinical research, epidemiological research, and health systems research. But this is not limited to conducting research in South Africa, and it is not limited to South African institutions. And I'm hoping that this platform can serve to support these young ones and emerging leaders. I also want to announce my commitment to continue to fund the emerging and young scientists that are part of this initiative so that we can encourage research. I would like to conclude by saying this has been a wonderful opportunity. In the last term of government, we have strengthened the centrality of health systems research within our efforts, and that will continue to do so. And I count on you as a community that we can invest in research and build capacity, particularly in this continent. I thank you.
Thank you, Madam DG. Please, can we do another energetic clap for our guests? Thank you, Ambassador Beck. Thank you, Madam DG. We bring this plenary session to a close, and I'm going to invite the Kwantu Sounds from the South African College of Music at the University of Cape Town onto the stage. And I invite you to dance. Please feel free.
What's wakalelinda wega kubuhlangwe emzini wakalelinda wega kubuhlangwe emzini wakalelinda wega chini ngangongo wakalelinda wega siyo ngangongo wakalelinda wega kubuhlangwe emzini wakalelinda wega kubuhlangwe emzini wakalelinda wega chini ngangongo
Good morning, ladies and gentlemen. The name of the band, it's called Kwantu Sounds. We specialize in African music, Southern Africa, and also outside Southern Africa. The instruments that you're going to play, it's a kayamba, an instrument that comes from Kenya, east of Africa. Please do enjoy. Thank you.
When